Okay, hi everyone. I'm Dr. Dharmi Kapadia. I work as a senior lecturer in the sociology department at the University of Manchester, and today I'm going to be talking to you about ethnic health inequalities. So what am I actually going to be talking about today? So I'm going to summarise some of the health inequalities that are facing ethnic minority people in the UK, which I will refer to as ethnic health inequalities. I'm going to discuss how racism leads to these ethnic health inequalities with a particular focus on mental illness. And then finally, I'm going to do a short section examining how ethnic minority people are treated in mental health care and how this might be another site of health inequalities. So first, if we talk about the health inequalities that are facing ethnic minority people in the UK, it's important to contextualise the experience of ethnic minority groups when we're thinking about their health. In the UK, in the United States, and in other countries that have seen large waves of migration, there's a history of ethnic and racial minority groups being discriminated against and faring worse on a wide range of life outcomes. So we can see that they fare worse in terms of employment in the labour market, they have poorer access to housing, they have worse outcomes in education and in the criminal justice system as well. And in the slides there, you'll see a link to our research centre, which is the ESRC Centre on Dynamics of Ethnicity. And we've got lots of research that summarises those inequalities. So when we think about physical and mental health, these are no different. There are serious and severe inequalities for ethnic minority people for these outcomes. And it's important to point out that these life outcomes are related to health. So poor housing, lower paid jobs, poor access to healthcare can all affect a person's physical and mental health. And in turn, these outcomes such as housing, employment, those can also be affected by a person's health. So it's a two-way relationship. When we think about ethnic health inequalities, the evidence shows that ethnic minority people have poor health across a range of health conditions and outcomes. So, for example, they have increased rates of self-rated poor health and well-being. So this is when on surveys or in the census, which we have in this country and other countries, when people are asked what their health is like, ethnic minority people are more likely to tick that their health is poor compared to white people. Ethnic minority people are also more likely to live a shorter life, so they can expect to live 3 years less than white people and up to 7 years less in a healthy way, which we call healthy life expectancy. They also report worse health-related quality of life. So we can see that these health inequalities operate in different kinds of ways that we conceptualize health. The other thing to point out is that there's health inequalities at every stage of the life course, from birth up to old age. So when we look at the evidence, we can see that in this country, in the UK, Pakistani, Bangladeshi, Indian, Black African and Black Caribbean babies are more than twice as likely to have low birth weight compared with white babies. And low birth weight is a risk factor, potentially, for other health problems later in life. If we look at people's teenage years, there's a clear health disadvantage for some ethnic minority groups in terms of asthma, obesity, and high blood pressure. And if we look at maternal health, these are just some examples, there are others as well. Black women are 4 times as likely to die in childbirth than white women. Asian women are twice as likely. And in addition, women living in the most deprived areas in the UK are 3 times as likely to die in childbirth. And a lot of this evidence, we've seen these health inequalities, we've seen them for decades within this country. But I think I'd just like to point out that the COVID-19 pandemic really shone a spotlight on these health inequalities. And we know that during the pandemic, ethnic minority groups in the UK and in other countries suffered the highest rates of infection and were at most risk of dying from COVID-19 virus. And it's no coincidence that those ethnic minority groups that were the worst affected by COVID-19 are also the ones that have a history of poor health and socioeconomic outcomes So in this country, that's the Pakistani, Bangladeshi, Black African and Black Caribbean groups. So this suggests that having high rates of COVID-19 during the pandemic or being at risk of death from the COVID-19 virus is not a result just of contemporary conditions, but also of historical racism, deprivation and marginalisation. And I think at this point, it's just important to talk about what I actually mean by racism. So I argue, and other scholars have argued, that racism is actually a fundamental cause of physical and mental illness in ethnic minority groups and is a driver of these ethnic health inequalities that we see. So it's a driver of the poorer health, physical and mental health that we see for ethnic minority groups. So we can think of racism as a widespread system of unfairly advantaging some ethnic groups while disadvantaging other ethnic groups based on their ethnic and racial background. And it's important to point out that racism, it takes different forms. So quite often when we think of racism, we're thinking of interpersonal racism. So this is racism such as physical or verbal abuse that people might be subjected to in personal interactions. But actually, it's important to think of racism operating in different ways. So we can think of racism as structural, institutional, or interpersonal. So structural racism refers to the processes that lead to disadvantage in accessing economical, physical, and social resources that are embedded within the structures of society. Institutional racism is legitimised by discriminatory policies and norms embedded in large institutions, for example, such as the National Health Service, NHS, and captures a broad range of practices that perpetuate differential access to services and opportunities within institutions. And interpersonal racism, as I just mentioned, refers to discriminatory treatment during personal interactions, such as verbal or physical abuse, but also refers to acts of ignoring or avoiding people due to their ethnic background. And we know that there's a lot of established evidence that shows that experiences of racism actually have a very detrimental impact on physical and mental health. And there's also a cumulative effect of this. So by this, I mean that the more racist experiences that someone has over their life, the greater the negative effect on their health. And this is particularly important when we're thinking about ethnic minority older people, as this disadvantage, these discriminatory experiences over the life course accumulate, which means that quite often health starts to deteriorate at an earlier age for ethnic minority people compared to white people. And second, as ethnic minority older people are more likely to face more racist experiences, the health inequalities we see in later life are larger than inequalities that we see at younger ages. And I just want to show you a chart which shows this from one piece of research that I've been involved in. On this chart, we've plotted some census data from the 2011 census. And on the chart on your left-hand side, you can see a chart for women, and on the right-hand side, there's a chart for men. And the horizontal axis shows the age of people, and the vertical axis shows the percentage of people who are reporting poor self-rated health. So the percentage that are saying, I've got poor health. And each of the lines represents a different ethnic group. The main message to take away from these charts is that we see much higher rates of poor health in ethnic minority groups at younger ages than we do for white groups. So for example, the rates of poor health for white British women in their 80s, so who would be considered in later life, is equivalent to or lower than the rates of poor health for Black Caribbean Indian women in their 70s and Pakistani and Bangladeshi women in their 50s, which means that you've got rates of poor health for Pakistani and Bangladeshi women in their 50s who are 30 years younger, which is the same, they've got the same level of poor health as white women in their 80s. So having just gone through some of the evidence that shows the extent of these health inequalities, and what they might be like across the life course, I want to focus on mental illness now. So the relationship between racism and mental illness. On this slide, I'm just showing you the rates of diagnosis of schizophrenia, which is considered a severe mental illness, and also detention under the Mental Health Act, which I'll go on to explain in a minute. So in this country, we can see from the slide that Black people are 5 times as likely to be diagnosed with schizophrenia compared to white people, and Asian people are 2.5 times as likely to be diagnosed with schizophrenia. So the rates of severe mental illness are much higher for ethnic minority groups than they are for white people. In addition to that, ethnic minority people are much more likely to be sectioned under mental health law. So this means if someone has a very severe mental illness and they are at risk of hurting themselves or others, and they need some intensive treatment, which means they have to be an inpatient within a psychiatric unit, there is a law in this country which allows a person who is ill to be compulsorily detained within a psychiatric inpatient unit. And this is seen as quite a coercive treatment. And there's lots of research, which I won't go into today, which shows that this can be very detrimental to a person's well-being. So those rates of detention are much higher for Black people compared to white people, so 4 times as high for Black people, and they're about twice as high for Asian people compared to white people. If we just think about the rates of mental illness, and I'll talk about the detention within psychiatric inpatient units in the final section, we have to think about whether those rates of severe mental illness are actually a reflection of the real schizophrenia or severe mental illness rates for Black and Asian groups in the UK. Now, of course, that I've explained in the previous section how racism can lead to poor mental health, so there may well be a higher rate of mental illness for ethnic minority groups. But we also have to consider that the diagnosis process that happens by psychiatrists usually for these groups. And there are psychiatrists who have commented on these rates, stating that actually these rates are really not as high as we imagine them to be, as we think they are, because psychiatric diagnoses are done for a particular purpose. And critics of psychiatry would say that these are done as a form of social control. So they should be seen as a socio-political diagnosis rather than a medical diagnosis. So I'll give you an example of what I mean by this. In the UK in the 1980s, there were stereotypical assumptions about Black young men, and they were associated with cannabis use or drug use. And within the medical field, they started to be given a diagnosis when they presented to GPs or psychiatrists of a diagnosis of something called cannabis psychosis, which did not exist before the 1980s. This was born out of stereotypes of Black men being aggressive, violent, and a big black and dangerous trope, which led to this use of a schizophrenia diagnosis for Black people in a way that it wasn't used for white people. And this pathologization or racialization of an ethnic group is not something that is new within this mental health field. We see a history of pathologization where behavior which may be seen as normal, in inverted commas, in other ethnic groups is seen as problematic in ethnic minority groups. So, for example, in 1960s in the United States, against a backdrop of the civil rights movement, some Black men were given a diagnosis of schizophrenia with notes being made by psychiatrists that their protests against white supremacy were indicative of some kind of psychosis. And we see it even further back during the 1800s, during slavery, where there was a pathologization of completely rational acts such as slaves running away from white owners, this was medicalized into drapetomania, the act of running away. So this idea of racialization that I just mentioned there, so it's based on the concept that there are, in inverted commas, separate races on which colonialism was predicated. And it describes the process of giving certain diagnoses or certain treatments to people based not only on their supposed race, but also based on what stereotypes or prevailing knowledges there are about people belonging to these supposed races, in inverted commas. So if we just think about why there might be these higher, if we just think about the ways that racialization and this pathologization of ethnic minority groups has happened, there has been a range of explanations for poor mental health. Some of them which are not really rooted in evidence. So I'm just going to go through 3 of these different explanations to give you an idea of some of the kind of misinformation maybe that there is about people's mental health. So there are cultural explanations that prevail that say that things like that a higher risk of psychosis for Black men is due to high cannabis rates. These are based on speculative and stereotyped cultural differences. They are not based within evidence. There are also some genetic explanations which try to state that because there are real different, in inverted commas, races, there are biological differences between them, and there are genetic markers of mental illness which show these that people are there's a different risk of mental illness between different, in inverted commas, races. But actually, there's not much evidence for this, because if we think about Black Caribbean people in the UK, so Black Caribbean people who've migrated to the UK compared with Black Caribbean people born in the UK and Black Caribbean people that have stayed in, for example, Jamaica, all those 3 groups show different rates of mental illness. And if there was some supposed biological explanation, we would expect to see the exact same rates of mental illness in those 3 groups, but there isn't. There's also explanations that state that, because a lot of ethnic minority groups have migrated to countries largely in the global north, those who migrated are at greater risk of mental illness, and the process of migration also increases that risk. So that's why ethnic minority people have higher rates of mental illness. But we actually see high rates for people who are born in Britain, for example. So that migration argument doesn't really hold out either. And that's why I'm trying to say in this talk that we really need to posit or show that racism is actually a fundamental cause of mental illness. And as I mentioned earlier, there's a lot of studies that have shown the link between experiencing racism and developing mental illness. So there's links to a couple of papers on this slide, which have used some survey data. So these are surveys of thousands of people who have been asked about their experiences of racism and their health within the same survey, so we can have a look at what the relationship is. And the surveys show that racist experience does lead to poor mental health. And just the last thing to mention in this section as well is that it's not only the racism that you experience that can lead to poor physical and mental health, but there's also evidence from studies that shows that racism experienced by people closest to you or people that you have an affinity with can also affect your mental health. And this is called vicarious racism. So there's a couple of links to papers on this slide. One shows that using another survey called the Millennium Cohort Study in the UK, mothers who had experienced racism affected their mental health, but it also affected their parenting practices, which led to poorer socio-emotional development in their children. So this is an example of racism being faced by mothers affecting the emotional development of their children. So that's vicarious racism. Another example, which I've put on this slide, talks about a study that looked at police killings of unarmed black men in the United States. And the study showed that police, when people viewed or heard about or viewed on the TV police killings of unarmed black men, this worsened black people's mental health in the US. And interestingly, there was no effect of the police killings on mental health if that person was killed when they were armed or if they were white and unarmed. So I think there's something in this study that shows it's the injustice of something that is happening to a racial group that you have affinity with or that you belong to that has the really bad effect on mental health. I'm just going to go on to our last section now and talk a little bit about ethnic inequalities in mental health care, not just in mental illness. So in this country, there is a very long history of poor treatment of ethnic minority people by the mental health system. And this is especially the case for people who are perceived as black, and we're seeing increasing inequalities for Muslim people as well. And there's been various initiatives in the past to try and address these inequalities. So one example of this is the Delivering Race Equality programme, which ran in the UK between 2005 and 2010. And this was the last time we actually had a race equality policy for mental health care to try and address these ethnic inequalities in mental health care. So since 2010, there is no race equality policy in the NHS for mental health. So this national programme was a response to the death of David Bennett, who was a British Black Caribbean man who died in a psychiatric ward whilst being restrained by 5 nurses, and that happened in Norwich in 1999. And the independent inquiry into that cited institutional racism as a factor in his death. So this Delivering Race Equality programme was a direct response to that, and its aims were to increase the appropriateness of services for ethnic minority people, increase community engagement to deliver those services, and improve ethnic monitoring, so recording ethnic group for patients in contacts with mental health services, so recording what ethnic group people are from, so that data can be compiled in relation, so we can actually see what inequalities there are. So I'll just bring back that slide from earlier, which shows the rates of detention under the Mental Health Act. So this is from a study which was which looked at lots of studies. So it was a systematic review, and it summarises that, we can see that the rates are about 4 times as high for black people and twice as high for Asian people when thinking about detention under the Mental Health Act. In addition to that, black people are much more likely to have police involvement when being detained under the Mental Health Act compared to white people. So they're twice as likely to have police involvement. So this is indicative of, more coercion or a worse experience for black people when going into mental health care. And it's not just at this more severe end of, because I think it's fair to say that being detained in a psychiatric unit is more at the severe end of mental health care treatment. There's other inequalities in healthcare, in mental health care treatment too, which I'm just going to give you a few examples of. So studies have shown that ethnic minority people are less likely to recover from an episode of mental illness, and they're also less satisfied with the services that they receive. And that was using some survey data from a survey called the Adult Psychiatric Morbidity Survey. We also know that patients with severe mental illness, so Black, Asian and Chinese patients with severe mental illness, are more likely to be given more intrusive treatments such as antipsychotic medication, which is injected, and are less likely to be offered talking treatments compared to white people. And if we think about outpatient access, so access to things like counselling or cognitive behavioural therapy, CBT, Pakistani and Bangladeshi women compared to white women are less likely to use those specialist mental health services, which may mean that they're less likely to be referred to those services by GPs. So even though we have all of these kinds of, well, many and varied examples of very severe inequalities in mental health care for ethnic minority people, there are people who still deny that there is racism at the root of these healthcare inequalities. And this quote on this slide is from an article that was published in the British Medical Journal quite a number of years ago now by two psychiatrists, who state that actually, if we put racism as the main explanation for these excess detentions under mental health care, they say it adds little to the debate and prevents the search for the real causes of these differences. They go on to say that in psychiatry, accusations of racism simply feed into ethnic minority communities' alienation and mistrust of services. So in this paper, they were arguing that we shouldn't be talking about racism in these services because this actually serves to alienate people and people are less likely to come and seek help. But as time has gone on, it's been much harder for people to deny that racism exists within the NHS and in other areas of life. And this is really, some of this is due to the COVID-19 pandemic, and some of this is also due to the resurgence of the Black Lives Matter movement, which really shone a spotlight on the inequalities facing ethnic minority groups. So racism denial has become much harder, also in the face of much more overwhelming evidence. So in addition to the evidence that I've already shown you, there was also some research in the past kind of few years which shows that there is still poor treatment on psychiatric wards. So Black people are more likely to be restrained if they're on a psychiatric ward, and they're more likely to be put into seclusion on wards, so being put into something like solitary confinement. We also now have, in order to try and combat some of these ethnic health inequalities in mental health care, even though we don't have a race equality policy in the NHS, we do have something that has been set up quite recently, which is called the NHS Race and Health Observatory, which has been funded to specifically address ethnic inequalities in health and healthcare. And there's a link to the website there so you can see more about their work. So just to kind of bring the lecture to an end and summarise what we've talked about, we can see that there's long-standing inequalities in health for ethnic minority groups. And we see, particularly in the examples that I've shown about mental illness and mental health care, these inequalities have continued to exist despite some attempts to try and address them. And we see some particularly severe inequalities for Black groups. And the main message that I'd like you to take away from this lecture, that racism is theorised to be a fundamental cause of these inequalities. And this racism operates at different levels: structural, institutional, and interpersonal. So thanks very much to you for listening to the lecture, and I hope it was useful to you. And I'd just like to acknowledge that this work was done with colleagues at our research centre, at the Centre on Dynamics of Ethnicity, and we've also had funding from a few different organisations there. Thank you.